welcome to today's conference call, Medication-Assisted Treatment for Opioid Use Disorder. My name is Hilda, and I will be your operator for today. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. At that time, to ask a question, you will need to press *1 on your telephone keypad. And now I would like to turn the call over to Ms. Julie Schmelzer. You may begin.
Thank you, Hilda. Good afternoon, everyone. My name is Julie Schmelzer, Project Specialist at Metastar, and I would like to welcome you to today's webinar, Medication-Assisted Treatment for Opioid Use Disorder, presented by Lake Superior Quality Innovation Network, or LSQIN. The LSQIN is comprised of 3 organizations, MPRO in Michigan, Stratus Health in Minnesota, and Metastar in Wisconsin, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement. We know that your organizations are working hard to improve healthcare quality and outcomes for patients diagnosed with opioid use disorder. Medication-assisted treatment can greatly improve patient outcomes, and we hope that what you learn today will be helpful in your practice. This webinar is part of the LSQIN Opioid Webinar Series. As Hilda mentioned, this session is being recorded and will be available in approximately 2 weeks on the LSQIN website YouTube channel. And at the close of the webinar, we will provide you with several evaluation questions. Please complete the evaluation so LSQIN can continue to provide events that are useful to you in the important work that you do. All lines will be muted during the webinar. However, again, keep in mind if you have questions at the end of the webinar, we'll have questions and answers following the speaker's presentation. We are pleased to have Eric Harum and Todd Molcenter with us today. Eric is the owner of Harum Consulting, LLC, a health and behavioral healthcare consulting firm. Harum Consulting offers large and small-scale technical assistance for all aspects of strategic planning, workforce development, as well as clinical and business systems design for states, institutions, and organizations. Eric's professional experience includes 25 years delivering, designing, and directing substance abuse treatment services in hospitals, correctional facilities, and community behavioral health centers. He is the Senior Manager for Correction Services with the State of Maine's Office of Substance Abuse, developing and managing adolescent and adult drug court services contracts. Eric is the National Implementation Consultant with the University of Wisconsin-Madison College of Engineering. He provides consultation to the State of Maine's Quality Counts, implementing screening, brief intervention, and referral to treatment, otherwise known as SBIRT, in Maine's patient-centered medical home. And he works on medication-assisted treatment expansion with the states of Ohio, Mississippi, Texas, West Virginia, and Maine. Eric served as co-chair of the U.S. Attorney's Task Force on the treatment and prevention of opioid dependence for the state of Maine. He provides countless hours of advocacy for improved access to addiction and mental health treatment in the Maine State Legislature, and Eric was president and board chair of the Maine Association for Substance Abuse Programs from 2007 through 2013. Eric lives in coastal Maine with his wife and 2 daughters. Our other presenter today is Todd Molcenter. Todd is the director of the Great Lakes Addiction Technology Transfer Center, or Great Lakes ATTC. He is a senior scientist at the Center for Health Enhancement Systems and Studies, otherwise known as CHESS, at the University of Wisconsin-Madison. Todd has spent the past 8 years addressing the opioid epidemic. I will now turn the presentation over to Todd.
Thank you, Julie. Really appreciate it, and appreciate everyone being on today. And really, we've seen the list of attendees and some very varied backgrounds and a lot of hands-on caregivers, which we're as well as administrators. So we're excited about that. With the center that Eric and I work with, we have worked, I think, on about 10 different state initiatives at this point to implement MAT, for opioid use disorders, and primarily a lot of our work has been around buprenorphine or Suboxone, Subutex, and Vivitrol with injectable naltrexone, and some with methadone. and we just see it as a great way to provide treatment. It's an evidence-based practice for treatment, and really we've just really enjoyed over the past 5 or 10 years working with different providers on implementing this practice. More specifically, what brings us to you today is how I change the slide is not working the way it did. Okay, I'll do it that way. And what brings us to you today is we are also here at the CHEST Center is the Great Lakes ATTC, and that means we service Minnesota, Wisconsin, Illinois, Indiana, Ohio, and Michigan, and provide technical assistance services there. So along with Eloquent, if some of you need additional help, our center, our SAMHSA-funded center is there to provide that assistance. Within the ATTC network, we really are in the practice of helping people and organizations incorporate effective practices into substance use disorder and recovery services wherever they reside, whether it's specialty treatment, primary care, emergency departments, what have you, because particularly with the opioid epidemic, people are showing up in all those places and desperately need help. And also with the Great Lakes ATTC, we are out of the University of Wisconsin, and then also if others are just interested in any assistance or just accessing our website and the like, this is the information for that. I'm providing that as a background of just sort of the work we've done and how we're really appreciative just to be able to share some of our knowledge with you today. And with that, I'm going to turn it over to Eric Harum, who he says he's our national implementation advisor. He's had wonderful experience in working in a lot of different states and is involved with a couple implementation collaboratives right now on this subject. So he deals with this on a day in and day out basis. Eric, the floor is yours.
Okay. Thanks, Todd. And I'm not seeing if I've had the toggle passed to my icon so I can advance the slide.
Let me see. Am I supposed to do that? Okay. Let me see. Yep, you're about to get it.
There we go. Thank you.
Mm-hmm.
Great. And so I appreciate that lead-in, Todd and Julie. And in reviewing the registration list, really an impressive spread of disciplines and professionals, being pharmacists and RN care coordinators, some case managers and quality improvement staff, a number of prescribers, and some recovery coaching staff. So glad to hear so many different people and the multidisciplines represented. What we want to try to cover here in about the next 30 minutes or so around the topic of medications for the treatment of substance use disorders are some basics about substance use disorders and treatments, to include some basics around neurobiology of addiction, some options in medications for the treatment of substance use disorder. We want to take a little look at the role of stigma and bias reduction as methods for improving patient engagement and retention in substance abuse treatment. And then lastly, look at a few examples of some successful models across different healthcare environments. So as that lead-in, really first and foremost, substance use disorders as a chronic condition, as with many chronic conditions, are really what we call a window of opportunity illness, meaning an individual's motivation for moving on, addressing, asking for help for a substance use problem. That motivation varies quite a lot throughout the course of a day and time. and that when a person does present and the opportunity of that window opens, really the best response is we are able to access treatment services for you. Come in now. Some myth busting, really alcohol, marijuana, cocaine, opioid use disorders, these as substances of choice really can be treated in the same programs, groups, and services. The idea that populations segregated by substance of choice for treatment is a bit of a myth that we want to debunk. Looking at acceptance, shame and stigma reduction, and skills necessary to cope with the day-to-day matters of life without returning to use are key components of those treatment services. Further, when we look at advances in research and the application of medicine within substance use treatment, we find that there are a number of medications that have proven to greatly improve outcomes for the treatment of alcohol and opioid addiction particularly. Contact with the general medical community where substance use disorders contribute to the problem focus offer key opportunities for engagement, and so that's within primary care, emergency medicine, ambulatory surgery, and as I'm sure many of you are finding, all of the different forms of patient-centered care or health home status. And these are, again, critical opportunities for engaging individuals in movement towards wellness. A little bit on terminology, the difference between dependence versus addiction, and particularly where the prevalence of opioid misuse, dependence, addiction, and accidental overdose are so prevalent in our country. Understanding the difference between these two presentations is important. Dependence simply is signified by the presence of tolerance and withdrawal. Individuals who take opioids, for example, at a prescribed and adherence level such that can produce tolerance will also produce withdrawal. In those individuals, there is a dependence present. The difference between dependence and addiction would be then the inclusion of pathological relationship, in other words, compulsive use of substances despite continued and progressively more harmful consequences, differentiating these two conditions. Some information about some of the opioids that we're finding most prevalent. This is just a picture to show you the difference between black tar heroin on your screen on the left, and really a comparison and contrast between dose equivalents of heroin and fentanyl side by side. There has been such an influx of fentanyl in many regions where I'm from, particularly in the Northeast, completely replacing heroin as an available street drug. And this just gives you the very clear sense of these are both essentially 30 milligrams, and you can clearly see how much less fentanyl is needed for that same amount, underscoring the danger and gravity of the situation. Also, heroin can come in different powder forms and different colors. Some information about naltrexone and naloxone, two different antagonists in the opioid medications. Naloxone having a very short half-life, shorter acting than naltrexone, 30 to 60 minutes for naloxone versus 8 to 12 for naltrexone. And naloxone, most notably known as the medication we hear about Narcan, used to reverse opioid overdoses. Or, for example, a naloxone challenge. Some information about naloxone overdose kits, prep, and administration with the prevalence of, again, opioid misuse an accidental overdose, particularly general health settings really need to be equipped with overdose preparation kits. We will not review the video link here, but that is for your information at a later time. This is a very brief 4.5-minute training video and is a great example of how simply staff can review and have a precepted sign-off on a competency for this, making this important medication more widely available. An example of buprenorphine and naloxone combination product, also known trade name as Suboxone, to just give you a sense of what that looks like in sublingual gel strip format. Many states had Medicaid formularies that have signed exclusive connections or conditions with one formulation of buprenorphine or another. The gel strip seems to be the most frequently occurring formulation of choice by state Medicaid formularies. And then finally, another example of a medication with strong efficacy and good research backing to improve the outcomes for both the treatment of alcohol and the prevention of opioid relapse is extended release naltrexone, also known as trade name Vivitrol. You can see from the photo that this is a IM injection, and recommend some training, competency, and perception for individuals who would be mixing and administering this injection. Now let's take a step back and look at addiction as a chronic condition and really delve further into how addiction works, in most notably the neurobiology. Addiction comes typically in 3 distinct stages, beginning with binge and intoxication, followed by withdrawal, negative affect and consequences, and finally preoccupation and anticipation. This video link is a nice brief 7-minute animated short that I think does a very, very good job illustrating these 3 stages, and wanted to include that for your future reference. Addiction resets the brain's reward system over time. Drug consumption triggers smaller and smaller releases of dopamine, and the reward system becomes less sensitive to stimulation, drug and non-drug related rewards, and less motivated by everyday stimuli, including relationships and hobbies. You begin to see increased signs of binge and intoxication with greater frequency. A way to think of this is individuals begin to seek the euphoria or lack of anhedonia or lack of a undesirable state through use and receiving less and less intrinsic reward from the day-to-day activities like going to work, taking care of your family, enjoying certain foods, etc. Those become increasingly novel. Further repeated exposure leads to adaptation, increased reactivity to stress, increased negative emotions, and intense motivation to escape the after effects of use, or what often is referred to as the crash. This is where we begin to see the signs from withdrawal or an ongoing negative affect when not under the influence. This is when individuals begin to say things like, I was using to feel normal and to function, not to seek euphoria. This further disrupts decision-making. Downregulation of dopamine impacting executive function, decision-making, self-regulation, weakening the ability to resist strong urges, follow through on decisions to stop using. And so this is really the cornerstone of what we're talking about, the beginning of saying addiction or substance use disorders are window of opportunity illnesses. And as you begin to see how this condition spirals, this is the example of why when those opportunities present, it's best to take advantage of those opportunities through engagement strategies. There is, of course, a very strong link between trauma and addiction. What we're talking about here is ACEs, or adverse childhood events, and in a number of different settings, we're increasingly seeing routine screens for adverse occurrences in individuals past, as we're finding a very strong correlation to the quality of a person's health over time in relationship to traumatic histories. An example of looking at this in terms of how that plays out in neurobiology or in overall development for individuals that have been exposed over time to significant traumas, often that repeat. There is essentially an 80 to 85% prevalence of significant trauma history in individuals struggling with substance use disorders, and that is true of both genders. Addiction as a chronic condition, and so this really is just to give us a comparison of addiction as a chronic condition and rates at which we expect relapse compared to other chronic medical conditions such as asthma, hypertension, and type 1 diabetes. Adherence to various treatment and medication regimes also is parity between these chronic conditions. Some brief information and I think a nice visual on understanding the 3 stages of opioid withdrawal, beginning with stage 1 up to 8 hours after last administration, strong cravings, followed by increased anxiety, depression, and moodiness. Within stage 2 at 8 to 24 hours from last administration, beginning to see stomach cramps. We call this everything runs. The person has watering eyes, a runny nose, upper body secretions, and increased restlessness, insomnia. You'll see a lot of yawning at this point. And then finally at stage 3, up to 3 days after significant diarrhea, fever, chills, muscle spasms, vomiting, including cardiovascular problems or risk based on patient. And so there, of course, are treatment options for folks with opioid addiction. These include behavioral treatments, education about the stages of addiction, that treatment can be effective, and there is hope. Relapse prevention strategies, plus medications that can assist to relieve the intense craving and preoccupation that drives so much relapse. And so let's look a bit here at buprenorphine more closely. As a partial agonist, in contrast to a full agonist like heroin, buprenorphine only partially occupies an individual's receptor. And includes a ceiling effect, meaning if we look in contrast between these 3 different medications, you'll notice the yellow line, methadone, meaning the higher the dose, the greater the effect up until the end of respiration. With an antagonist, the bottom gray bar, like naloxone, Narcan, or Vivitrol, you do not see any of the receptor activity being activated, rather it's blocked and therefore not affecting respiration. And then finally, buprenorphine as the partial agonist, partially occupying receptor sites and activating them, though not totally lighting that system up. Does have a ceiling effect at 32 milligrams, meaning there will not be greater therapeutic gain when adding additional milligrams on top of that. Also, buprenorphine has a very, very strong receptor affinity, so much so that when presented in the system with heroin or other opioids on the receptor sites actively, buprenorphine will replace them. This is what is also known as precipitated withdrawal. And then finally, buprenorphine dissociates very, very slowly. The speed of disengagement or uncoupling from the receptor, as you can see in contrast to heroin or other short-acting opioids. And in this way, though there's a relatively short half-life, the staying connected allows for ongoing coverage of craving and preoccupation for individuals over a much longer period of time. So this really is kind of the cornerstone slide from 2003 in the Lancet that looked at treatment retention for opioid dependence with medication-assisted treatment with buprenorphine versus no medication, with the group receiving no medication being the green bar that goes down steeply and to the left. That is the duration of treatment over the course of the year-long study, noting that all of the participants without medication-assisted treatment dropped out within 60 days versus 75% of the buprenorphine sample being retained in treatment for up to a year. And in fact, this is not a study that can be replicated as 20% of the control group died, which is further underscoring the necessity of expansion of these treatment services given the nature of opiate dependence in our country. So when you put it all together, buprenorphine binds very tightly, occupies the receptor for long periods of time, though not fully activating it, with a ceiling to the opioid effect. Because of this, when buprenorphine is on board, it blunts the effects of other opiates and is relatively safe in terms of an overdose profile. And this is one reason why when we talk about medications for the treatment of substance use disorder, these are classes of medications that do work as designed, intended, and the literature provides. And that is always the case in our world of behavioral health. So these are very strong endorsements. So now let's look a little bit at the role of stigma and then finally some examples of other successful models. We'll be able to turn this back to Todd and we start to wrap things up and have some time for Q&A. So what we know is that, and forgive me, these are going to be specific to the region I reside in and am working predominantly here in Maine, that with greater than one death per day, the current system of substance use care and treatment for opiate addiction is inadequate. And we want to recognize that substance use disorder treatment works, particularly the addition of these medications in combination. This really is the evidence base and gold standard is the combination of these with recovery support services. Most withdrawing from opioids need medications, but do not need inpatient or necessarily residential treatment. Opioid withdrawal is very uncomfortable, though rarely fatal, and folks with substance use disorder need treatment when they are ready. Waiting lists don't work, and so if we go back to the neurobiology slide where we started to identify how that starts to play out for an individual over time, underscoring substance use disorders as a window of opportunity illness, hanging out on a wait list for 2-3 weeks or longer is ultimately gaps that individuals fall through. So when we look at some effective models that are worth consideration of replication, I am pleased to report on some of the programs that I've been involved with, that we understand that access to addiction treatment integrated with MAT does result in decreased mortality rates from overdose. In the communities that I've operated services for a decade or so, Bath, Brunswick, which is in the mid-coastal region of our state, where we've had the full array of treatment services integrated with MAT and do not run wait lists, there have not been reported overdose deaths in 8 consecutive quarters through that established hub and spoke model of care. That's a community combined of around 50,000 individuals, and elsewhere in Maine with similar population densities and demographics, there would be 15 to 17 deaths per year, or around 30 in that same time frame. And indeed other areas of the state where services are not readily accessible have experienced ongoing increases in the frequency of fatalities from overdose. When we began providing medication-assisted treatment on site, what we learned was that our retention or our engagement rates for individuals with opiate use disorder went from around 25% to 85% following the integration of medications with all of the treatment services, and it was really just such a night and day difference on individuals continuing on in services. We've been able to combine medication-assisted therapy with recovery coaching services in one of our county sheriff areas, and they refer individuals to our programs for MAT and treatment and recovery coaching as a diversion program from county jail. We've been able to trend some of our clients in the past at 6, 12, and 24 months, and are finding our re-arrest rates are far lower than national averages. Also, that these individuals at 2 years out are sustaining full-time employment rates at very high percentages within their overall cohort, becoming successful contributors to their communities, taking care of themselves, obtaining insurance, etc. Other promising practices, combining ASBERT services for screening for substance use risk within obstetrics and making those strong clinical pathways to treatment, including medication-assisted treatment, has been a project that has, I think, gone well and has produced some strong outcomes. An example of that is in the first year of building those clinical relationships between service providers, the overall length of stay in NICU post-delivery was substantially lower than the national average, as well as the average DRG per discharge for those patients. Ultimately, in the first year following 17 births, the cost reduction year to year was almost $250,000 directly to the Medicaid program. And lastly, this is another healthcare system in the southern part of Maine that has adopted a hub and spoke model of service delivery, where they have a addiction treatment and behavioral health department delivering a full complement of ambulatory treatment services and have developed capacity with two primary care providers in each of their 10 primary care offices in the region to receive stable maintenance patients from the hub or the treatment center who have reached the maintenance phase of care with their recovery, including medication-assisted therapy, and ongoing prescribing as a part of their overall primary care as they move out into the spokes. And if individuals should decompensate, the reason there are double arrows is so they can return from the primary care office for restabilization. Some final projects coming up in the year, improving rapid induction, in other words, getting people seen within 24 to 72 hours from intake, developing capacity, and have implemented the dispensing of buprenorphine in the emergency room, as well as instituting ambulatory protocols for alcohol withdrawal, with handoff to the ambulatory addiction treatment program. And then lastly, getting individuals on inpatient units that have IV drug-related infections and long lengths of stay evaluated and access to medication-assisted therapy products while they are in inpatient. And that is where I will pass the slides back over to you, Todd.
There? Okay. So, yeah, Eric, thanks for your presentation. I think it really did a good job of setting up the need for medication-assisted therapy, as we call it in the field, and how it works, and in ways health systems are using it, and the fabulous results there too, on at the very least overdose deaths. And I'm sure there's other sort of results around just need for health care and impacts on families and the like. And so, having said all that, I guess I'll turn it over to the audience to ask what questions they have, and Eric, you can obviously certainly help in answering.
Hilda, this is Julie. Do we have anyone in the queue with questions at this time?
We don't have anyone. As a quick reminder, if you have a question, please press *1 using your telephone keypad. We have a question from Mr. John Glover.
Hi, Eric. I really appreciate your presentation today. One of the things I'm really impressed with that you spoke about quite a bit was the rapid move into treatment within 24 hours or right away, and that window of opportunity. Could you talk a little bit about what kind of things you did to get that to happen? I think that can be a real stumbling block for a lot of practices.
Absolutely, and clinical environment is an important aspect of how you would design that. And so, the way that we might describe that for a primary care office versus a community treatment program or other healthcare, department or presentation would vary. Is there a particular environment that you have in mind?
Yeah, I'm thinking more of primary care. They often, are concerned about getting that follow-up. So I'm just wondering how you managed to get that really quick turnaround. I agree with you that people struggling with addictions benefit greatly from being able to act during that window.
Right, and so if a individual presents at primary care and the primary care office does not have capacity, meaning physicians with, for example, an X waiver, to assess and potentially start an individual on a medication-assisted therapy regime. A relationship and defined pathway with a treatment provider locally that does have that capacity would be one important step in initially developing that. Where a primary care office may have that capacity and has, gotten it identified and trained staff in delivering MAT services within that environment, there's just a range of different ways that can occur, and many primary care offices actually offer very good clinical environments to do that, meaning, access to point-of-care urines or other labs, the potential for integrated behavioral health on site are all strengths in sort of the triage and assessment that can, speed up that process for folks. Typically, these occur as an add-on to a problem-focused presentation. Maybe someone comes in and they're in withdrawal and seeking help for that, and the conversation shifts to one of seeing if they are willing and interested in being engaged in a more formal treatment process. And so those are, in a nutshell, some of the ways that I would start to look at ways to improve access. Is either developing the clinical capacity internally, or for sure developing a strong pathway and referral relationship with locations that can do that.
Thanks.
Yep.
We have another question from Molly Callahan.
Hi, I just wondered if you could elaborate on the hub and spoke design. I saw that term and was just curious if you could elaborate on what that means.
Sure. Really taken from other industries as models of service that can handle throughput, volume, and promote a lot of movement. And so hubs we would define as typically specialty behavioral health environments or substance use treatment facilities, and ideally locations that can provide a full continuum of treatment options that are also co-occurring, meaning able to assess, evaluate, treat, and stabilize both mental health and substance use presentations. Often with psychiatry and addiction medicine available and accessible to folks across that continuum of care. This allows for the highest acuity presentations to be most rapidly engaged, evaluated, and begun moving towards stabilization, with spokes traditionally being more general clinical environments like primary care offices, where patients can be referred to for ongoing maintenance along with the rest of the items that they may otherwise have on a problem list. Recognizing that when patients move into the maintenance phase of care with a chronic condition, there is a lot of similarities, whether that individual is in terms of strategy, whether the person is in the maintenance phase with a cardiac chronic condition or a substance use disorder. That level of self-efficacy is and can be appropriately managed in the primary care environment, and that's what we define as spoke. Recognizing that patients can and should be able to move back and forth between those environments as one of the nature of all chronic conditions is relapse and remit. And so that's sort of a brief way that I would want to define that.
Great. Thank you, Eric. This is Julie. We had a question in the chat that says, will you send a copy of the presentation software? That's a question from Peter Gooby. And I wanted to just say that the slides and the recorded presentation will be available in approximately 2 weeks on our LSQIN website YouTube page. So if you click on past events, it'll link you to that YouTube page to watch the presentation, and then you'll have the slides. And then we also had a question in the chat from Karen asking, Eric, can you speak to some of the interventions that you implemented to reduce the stigma among clinicians?
Yes, and and I'll just say it's hard work. The clinical recipes here are the easier part of these implementations. The way folks feel about it is often the challenges, as with any changes that we take in our work. And so first of all, there's some basic competencies that are very, very helpful, and that is the training, meaning, a 30 to 40 minute in-service with some form of validation at the end, a short quiz or something of that nature. And the reason these are competencies and that they're validated is because these are things that then live in personnel files and become standards that we supervise to. And so that's an important component here. Within those competencies, one, the neurobiology of opioid addiction, or the neurobiology of addiction in general. Two, benefits of urine drug screening. Three, pregnancy addiction and other specialty populations. And last, the recognizing the signs and symptoms of oversedation and what to do. We find that with those four in-services as competencies, signifying, around 2 hours of content, you do see a pretty strong reduction in initially presented stigma or bias from the clinical staff. Doing a training next week for a multidisciplinary team in an emergency room that will be security, staff, and RNs in an ER that is now prescribing or dispensing buprenorphine with certain opioid presentations. And they are recognizing in that environment that the language used can either really improve engaging folks in that option, or it can work in the opposite direction. And so we're including in that training some information about scripting and just being a little bit more rehearsed and purposeful, practicing some of the language that can be more engaging for patients can really make a big difference. And recognizing that it does take practice. And so that's some strategies that we've used to try to affect stigma and bias.
Thank you, Eric. I see our evaluation questions are up on the screen, so if folks want to take a moment to complete those, we certainly still have time for some questions. We have about 10 minutes left. I don't know if you have any other folks in the queue, Hilda, or anybody with questions?
Thank you. At this moment, we have no other questions.
All right. If there are no further questions, Todd or Eric, is there anything else you wanted to add to the close of the presentation?
Yeah, this is Todd Mulfetter, and if people have other interests or questions around MAT, or use of opioid use disorder pharmacotherapy and replacement therapy, the Great Lakes ATTC is here, and we'd be happy to help people with their questions or any kind of training needs they might have. And it would certainly coordinate with the Alquin, because it's been a great relationship.
Thank you, Todd. And I will add that your contact information was at the beginning of the presentation in your slides. So if individuals want to reach out to you, that would be the way to do that. And Emily, I appreciate you putting the questions up on the screen. If we don't have any further questions and you've completed the evaluation, I think this concludes today's educational session. I will just mention again, this presentation will be available on our LSQIN website and our YouTube channel in approximately 2 weeks, and that's www.lsqin.org. And I just want to take this moment to thank Eric and Todd for sharing this valuable information with us today, and thanks to all of you who joined our webinar this afternoon. Enjoy the rest of your day.
Thank you. Ladies and gentlemen, this concludes today's conference. We thank you for participating. You may now disconnect.